Hi everyone. So I'm waiting for Dr. Vandergambi to join. Okay, just in a while.
Okay.
السلام عليكم ورحمة الله.
أهلا دكتور بندر. عليكم السلام.
وعليكم السلام.
Inshallah, we'll start soon. Sorry, I just received the link, so. Can you see the slide?
Yes, doctor.
Okay. Bismillah ar-Rahman ar-Rahim. So today we'll go quickly over ECG review. And basically, we'll discuss the ECG basics, ECG changes in ischemic heart disease. If there is time, most likely this will be another session, arrhythmia ECGs, brady and tachy arrhythmia ECGs and others. The first part is very basic, but you know, when we talk about ECG, it's always good to go to the basics and just make sure that everybody remember what is the ECG and the basics of the ECG, the leads location and others. It could be a little bit boring, but when we go to the ECG and ischemic heart disease and others, it will be case-based and inshallah it will be more interactive. So we know that ECG is there for more than 120 years. And if you look to the ECG as part of the cardiovascular evaluation, it is one of the most commonly used tests. It is readily available, it is simple, and it is easy to do, but it's important to interpret it right to reach a diagnosis. The history of ECG goes back to the 16 and 1700s, but the most landmark studies started in 1842. First is recording electrical activity from a frog. It was in Italy. Then in UK, there was development of first electrical activity from human heart was recorded. Infinivin, well known for his contribution, and he is the one actually that gave the name electrocardiogram. He is from Netherlands. And he started actually recording the 3 leads, which is the typical bipolar limb leads. And he won Nobel Prize for that work in 1924. Then from United States, Wilson invented the Wilson terminal or the central terminal. And by that, we start to have precordial leads in between 1934 and 1938. And from the same concept, later on, Goldberg from New York invented the augmentation lead. So we have now the 6 leads in 1942. And 1954, AHA standardized the 12-lead ECG, and it is what we see now, right now. So it took long time for ECG to develop, and it is very useful. The first ECG machine, as you can see here, is very complex, very huge, and normal saline to have good connection. But over the years, we have now the portable ECG machines in each unit, and we have actually very small devices nowadays. Some of them, like this one, can be handheld with good quality. Going now to what ECG means. We know that in the myocardial cell, we have the depolarization and repolarization, and this depolarization and repolarization activities resulted in contraction and relaxation of the cardiac muscle cell itself. If we have electrodes outside the body, and we are recording these electrical changes within the heart between these electrodes, then we have what we called ECG. So what is ECG? It is a graphic representation of the heart electrical activity. It is a graphic representation of the heart electrical activity by electrodes placed on the body and in the chest and in the limbs. Okay. So we know that the sinus node is the pacemaker of the heart. Action potential started in the sinus node, spread from cell to cell in the sinus node, then to the right and left atria, then goes down the AV node, right and left bundles, and the ventricular myocardium. Summation of all these action potentials within the atria and the ventricle and the conduction system produces the 12-lead ECG. It is not an action potential, it is summation of all these electrical activity within the myocardial cells. By the way, you can interrupt me anytime, please, if you have any question. And as I mentioned, sorry for the first part, I know it is, you know this from before, but it's just good to remind you with this. So in the 12-lead ECG paper, we have the baseline, and anything above the baseline is positive wave, like the R wave here, for example. Anything below is negative, like the S wave. Here is the T wave, it's positive this time, but it can be negative if it is below the baseline. And it's important from the electrical point of view to understand the concept of electrodes. So these electrodes, we usually have positive, negative. And if the wave of depolarization, the main vector of that, is moving towards the positive electrode, it produces upright deflection or a positive deflection. If the wave of depolarization is moving away from the positive electrode, it produces a negative deflection. What will happen if it is perpendicular to these electrodes? So if the wave of depolarization moving this way, there is positive part and there is negative part, and they will equal each other. So they will cancel each other, and we will have isoelectric line. So if you look at the electrodes, and just imagine each electrode is a camera looking for the activity of the heart, electrical activity of the heart. If the wave of depolarization is moving in this direction, this electrode will just show negative deflection because all the depolarization wave is moving away from the electrode, so it will produce negative deflection. This electrode will have a positive deflection because the wave of depolarization is moving towards this electrode. If you look to the one in the middle, which is the wave of depolarization perpendicular to it, it will have positive and negative, and they are equal to each other, so they will cancel each other. What will happen to this electrode here? More of depolarization wave is moving towards, so more positive, and little is moving away from it, so small negative. If you take this other electrode here, it's the opposite. Most of the wave of depolarization is moving away from it, but a little going towards this electrode, so we have small positive and then more negative. Remember the ECG waveforms, the amplitude is variable. It depends on the myocardial mass. So if somebody has ventricular hypertrophy, we will see bigger R waves than somebody without ventricular hypertrophy. The net vector of depolarization affecting the signal, the properties of the intervening tissues, and the distance between the electrode and myocardium. So if somebody has precordial fluid, it is separating the heart from these electrodes, so we will have a small signal. The same for somebody with pulmonary emphysema or obesity, the electrodes are away from the heart, so the signal would be low because of these factors. We know that the 12-lead ECG has 6 leads, what we call limb leads, and 6 chest leads. The heart is three-dimensional structure, of course, and to record electrical activity of the heart, we have to look at least from two different angles. So the limb leads look to the frontal plane of the heart, and the chest leads or precordial leads look to the horizontal plane of the heart. I'll remind you with these leads, I'm sure you remember them, but just as a reminder also. So we have three limb leads, lead 1, 2, 3. We have the three augmented leads, AVR, AVL, AVF. So these six called 6 limb leads, as you know, and 6 precordial leads, V1 to V6. We'll take them one by one. Lead 1, we know that we have, it is true bipolar. So we have 2 electrodes in the body, the left electrodes in the right arm, and the positive electrodes in the left arm. And remember, the activity of the heart started from sinus node, up, down, right to left. So we have the lead 1 here. Lead 2, the negative electrode, again, the same, right arm, but the positive electrodes in the lower limb. Lead 3, negative electrodes in the left arm and the positive electrode in the lower limb. So just concentrate on where is the positive electrode for each lead. So positive electrode for lead 1 is the left arm. So if something moves towards this part, it will be positive. Moving away from this part will be negative. The lead 2 and 3, we call it inferior leads because actually they are looking to the inferior surface of the heart. Augmented leads, we are using the same electrodes that we have in the left arm, right arm, and lower limb, but we record from this electrode and we calculate the other electrode or potential as a reference point, 0 point or electrical point away from the heart, at the center of the heart. It is calculated by the machine. So we are using the same electrode in the right arm with another point in the center of the heart calculated by the machine. So in that case, we have the augmented vector right. If you use this electrode in the left arm, we are using the augmented vector left. And for lower limb, augmented vector left. And it's called augmented because the signal we are recording is very small. It has to be amplified by the machine so we can see it like other signals. So looking to the bipolar leads, lead 1, lead 2, lead 3, to know abnormal, you have to know the normal first. So normally lead 1 has positive P wave. Why? Because the activation of the atria is up, down, and right to left. So it is moving towards lead 1. So P wave is positive. Activation of the ventricle is from up, down in this direction. So mostly towards lead, the positive electrode of lead 1. So positive R wave and T wave. Lead 2, the same. It is here in the inferior surface. So P wave would be positive. QRS complex would be positive. Lead 3, the same. If you notice here, the R wave here in the lead 2 is usually bigger than R wave in lead 3 and lead 1 because the activity of the heart is moving mainly towards lead 2, which is here in this area. The augmented leads, AVR is here. Activity of the heart is away from it. So the P wave would be negative, QRS complex is negative. AVL is similar in some extent to lead 1. So we have usually positive P wave and maybe bidirectional QRS complexes. For AVF is the same as lead 2 and 3 because it is in the inferior surface of the heart. So we have positive P wave and positive QRS complexes. When they did actually the infinite triangle and they calculated it from the center of the heart, lead 1 is 0, lead 2 is 60 degrees, lead 3 is 120 degrees. For the AVL is minus 30, AVF is plus 90, and AVR is minus 150. Don't bother yourself with these ones, but later on when we discuss the axis, just remember where is the positive part of the lead 1, which is here, the negative is here. For AVF, here is the positive, here is the negative. Where is positive, where is negative? We didn't need to know exact degrees to calculate the axis. For precordial or chest leads, there are 6 of them, as you know, V1 to V6. Remember the location of each electrode. So in V1, it is 4th intercostal space to the right of the sternum. V2, the same level, but to the left of the sternum. So these two electrodes here are looking mainly to the septum and also looking to the right ventricle. The V4, is located in the fifth intercostal space at the mid-clavicular line. V5, V6, the same level, but at anterior and mid-axillary line. V3 is between V2, V4, so it's just in between the two. And if you look again to the location of these leads, 3, 4 is looking mainly to the anterior surface of the heart. V5, V6 looking to the lateral surface of the heart. We'll discuss this again with ischemic heart disease and localization of ST segment elevation. Again, each lead is like a positive electrode, and the central terminal is the negative electrode calculated by the machine. So anything moving towards this electrode is positive, away from this electrode is negative. How do they look like? If we start from V1, the P wave in V1 could be small positive, small negative like this, and this is the common thing. The first part is activation of the right atrium because the sinus node located in the right atrium. The second part, which is the negative part, is activation of the left atrium, is moving away from V1. It can be only small positive, small negative. So it is accepted to be small positive, small negative like this, or just small positive or small negative. If you look to V1, mostly the activity of the heart is away from it, so you have only small r, deep S. V2, the r gets bigger, V3 bigger, and then more till we reach V5, which is the maximum r usually, even bigger than V6. This is called normal R wave progression. R wave gets bigger and bigger till we reach V5, and then it's a little bit smaller in V6. The usual transition where R is more than S is at V3, but could be also V4. If the R is bigger than S in V2, we call it early transition. If it is later, it's called late transition, or what we call it poor R wave progression. It may have clinical significance like myocardial infarction, sometimes may not have clinical significance. As I mentioned earlier, I wouldn't bother you with this hexaxial lead diagram, but basically when the intervention triangle lead 1, lead 2, lead 3 is taken to the center of the heart, we find that lead 1 will be 0 degree, lead 2 60 degrees, and the lead 3 is 120, and as I mentioned earlier, AVL minus 30, AVR minus 150, and AVF is 90 degrees. Okay, so let's analyze the ECG based on the anatomical correlations. We know that P wave represents atrial depolarization. So when we have depolarization in the atria, we have a P wave. If there's any atrial abnormalities like right or left atrial abnormalities, we expect to see changes in the P wave. Then the signal goes through the AV node. We have the PR interval. When the ventricles are activated, we have QRS complexes, so representing ventricular depolarization. And then when we have repolarization, it would be the ST segment and then the T wave. So basically, when the sinus node fires, we will not see anything in the ECG. Why? Because it's small amount of tissue. Electricity produced by the sinus node is small to be detected by electrodes outside the body. However, when it activates the right and left atria, we have the atrial depolarization, we see a P wave. When the impulse conducted down the AV node and the conduction system, we have the PR segment, Purkinje fibers corresponding to the Q in the QRS complex. When the ventricle depolarizes, we have the QRS complex. During repolarization, we have the ST segment and the T wave. And this is what is happening with each cardiac beat. Activity starts from sinus node, spreads to the atria, conduction system, and the ventricle. And we are continuously recording the P wave, QRS complex, ST segment, T wave. And if there is any abnormalities, then we have a different signal that we will discuss later. I know it is very basic, but just as a reminder for you with the 12-lead ECG. So the layout of the 12-lead ECG, this looks what we have in our hospital, but it can be different from hospital to hospital. The common layout is like this. We have the limb leads in one side and the chest leads or precordial leads in the other side. limb leads, the bipolar, lead 1, 2, 3 in one side, followed by AVR, AVL, AVF. Then we have V1 to V3, V4 to V6. And we have rhythm strip down, which could be 1, could be 2, could be 3. In our hospital, usually we have 3 rhythm strips. When we start analyzing ECG for rhythm part, we start with the rhythm strip here. Then we go to assess other leads. In other hospitals, you will see that they put at one side the 6 limb leads. So AVR, AVL, AVF is down here, and V1 to V6 on the other side, and the right-hand side, and the other side, and the rhythm strip below that. So you could have this layout or the other layout. When you see the ECG, just familiarize yourself, is it this or that layout, and then start analyzing it. Any questions so far?
No, thank you.
Okay, so the ECG paper, as you know, we have 2 parts. It's like a syllabus continuously recording the electrical activity. So we have 2 planes, the horizontal in the paper and the vertical. Horizontally, we are recording the time, and vertically, we are recording the voltage. So time and voltage. And I'm sure you know already this, that the small square or small box in the ECG is 40 milliseconds. And the large one is 5 small ones. So it is 200, because 40 by 5 is 200. And if we take 5 of this, it will be 1 second, because each one is 0.2 of a second or 200 milliseconds. So 5 large boxes is 1 second. This is from the time point of view. From the voltage point of view, the standard is to have 2 large boxes as 1 millivolt. 2 large boxes, it means 10 small boxes as 1 millivolt. So each one is 0.1 millivolt. Again, small box is 40 milliseconds, large is 200 milliseconds, 5 large boxes is 1 second. The important intervals, and we will come to them later when we discuss abnormalities in the ECG, the PR interval from the beginning of the P wave till the beginning of the QRS complex, it is 120 to 200, which is actually, if you remember it by the number of small boxes, is 3 to 5. 3 is 120, 5 is 200 milliseconds. QRS complex width is usually 1.5 to 2.5, so 60 to 100 milliseconds. It is absolutely abnormal if it is more than 3, more than 120 milliseconds. The QT from the beginning of QRS complex till end of T wave, it's between 360 to 400 milliseconds, less than 360 short QT, more than 440 is prolonged QT. And 440, it means 2 large boxes and 1 small box. So 2 is 400, 1 small box is 400, is 40 milliseconds. So 440 milliseconds is the expected upper limit for QT interval. This is just color coded, reminding you what the usual intervals. When we see we're looking for RR, it means actually if you take time from this R to this R, it is time from one cardiac beat to another. So the RR intervals, it can give you the idea about the heart rate. We have the PR interval, we have the QRS complex duration, the QT interval. The PR segment and the ST segment, ST segment is important when we talk about ischemia, but the PR segment is mainly as baseline that you can see if ST segment is above or below the line. The line would be from the PR segment. But the duration of PR segment is not important. The duration of ST interval is not important. Okay, when you analyze ECG, you have to be systematic and use it all the time the same way, so you will not miss any information. Usually, I prefer to start with the 3 R's. Number 1, the heart rate. If you start with the rate, it can tell you if the patient is within the normal range, which is 60 to 100 beats per minute, or if the patient is bradycardic, less than 16, or tachycardic above 100. Regularity, if it is regular, this is most of the rhythm that we have is regular. Irregular, then your differential diagnosis would be to look for atrial fibrillation or atrial flutter with irregular, with variable conduction or multifocal atrial tachycardia, or if there is premature atrial or ventricular complexes. Heart rhythm determined by the rate, regularity, and the absence or presence of P wave before HQRS complex. So if you have P wave before HQRS complex, and P wave morphology is what you expect from sinus node, and the rhythm is regular, rate is within 60 to 100, we say this is normal sinus rhythm. If not, then we determine the rhythm based on the rate, regularity, and other parameters. Then you can look for the conduction, PR interval, QRS duration, QT interval, cardiac axis, then P wave morphology, is it right or upright, or is it normal, I mean, or abnormal, QRS morphology, normal or abnormal, ST morphology, and based on all of this, you reach your conclusion, and especially if you have previous ECG to compare with, if there is a significant change compared to the baseline ECG. Okay, for the heart rate, you know it well, but just as a reminder for you to just quickly get the heart rate, we know that when we mentioned that 5 large boxes is 1 second, so in 60 seconds, we have 300 large boxes. So if you wanted to know the heart rate, we take 300 divided by the number of large boxes between the R to R. We mean R is 1 beat and the other R is another beat. So if the distance between one R and another is 1 large box, 300 divided by 1, because it's here 1 large box here, it's 300 beats per minute. If we have the R to R is 2 large boxes, 300 divided by 2 large boxes is 150 beats per minute. If 3, it's 100 beats per minute. If 4, 75. If we have 5 large boxes, it is 60 beats per minute. If we have 6, it is 50 beats per minute. So we just take the 300 divided by the number of large boxes between the R to R, and it gives you the heart rate. If you want it to be more accurate, you can just use 1,500 and divide the distance between the 2 in small boxes. Cardiac axis, what it means? It is the average direction of the heart's electrical activity. When the sinus node fires, it activates the atria in different directions. However, if we look to the average direction, this is the axis for the P wave. And again, when it goes down to the AV node, it spreads to the right and left bundle branches. It goes in different ways, different directions, all the way. However, if we take the average direction of the heart's electrical activity in the ventricle, this is the cardiac axis. And the cardiac axis normally lies between -30 to 90 degree. -30 to 90 degree. This is the normal axis. You see in some textbooks between 0 to 90 or between 0 to 100, but the commonly accepted is between -30 to 90. If the electrical activity, the average electrical activity of the heart goes in this direction, whether here, here, or here, it is still within the normal range. And the best to look for cardiac axis is to look for lead 1, which is a lateral lead, and AVF, which is inferior lead. If both are positive, then likely the axis is normal. Okay. If the axis is in the left side, it means to the patient's left hand side, so it will be in this range. Lead 1 here is positive. However, AVF would be negative. So if we have lead 1 positive and AVF negative, we think most likely it is left axis deviation. But there is one thing here. Remember, when you have left axis, you have to confirm it by looking to lead 2. If lead 2 is negative, this is okay. It means that the axis is in this range between -30 to -90, left axis deviation. However, if I have lead 1 positive, AVF negative, but I look to lead 2 and it is positive, it means it's still in this direction. It's not up to the left, it's still within the normal range. So in that case, we say no, still axis, normal axis. So this is the only exception. If I have lead 2 is positive, even lead 1 is positive and AVF is negative, we see the axis is still within the normal range. For right axis is easy because in this part, lead 1 is negative, AVF is positive. So whenever I have this, I say the patient has right axis deviation. This part here, extreme axis, could be extreme left or extreme right. We will have negative lead 1 and AVF, both will be negative. And in this case, we can sometimes call it indeterminate axis, could be extreme right or extreme left. And this, we see it mainly with ventricular tachycardia, very abnormal activation of the myocardium. Why we need to know axis? Because it can be the first clue to know if there is pathological abnormality. So if you have left axis deviation, could be because of left anterior fascicular block. We know that the left bundle has anterior and posterior fascicle. If the anterior fascicle is blocked, activity is going to the left side. posterior to anterior, so left axis deviation. With left bundle, also you expect to have left axis deviation. If you have left ventricular hypertrophy, of course, if the left ventricular mass is huge, the vector of the heart will shift to the left, so we will have left axis deviation. If you have inferior myocardial infarction, in AVF, you expect negative KRS complex, so it will give you left axis morphology or left axis criteria. Some ventricular ectopics, based rhythm in the right ventricle will give you left axis deviation. Certain types of Wolff-Parkinson. Wolff-Parkinson-White syndrome is accessory pathway, as you know. It depends on the location, whether it is in the right atrium or the left, in the around the tricuspid annulus or around the mitral annulus, it can give you left axis deviation or right axis deviation. For right axis deviation, the opposite. If you have right ventricular hypertrophy, lung diseases, COPD, left posterior fascicular block, lateral infarction, and some other like Wolff-Parkinson on the other side, it can give you right axis deviation. Right axis deviation could be also normal variant in children, in thin people. So, okay, let's do this one. Somebody can please give me what do you think about the cardiac axis in this ECG? Is it normal or abnormal? Just cardiac axis for now.
Normal axis.
Why?
When you look to the lead one and lead AVF,
Yeah,
you see both of them are positive.
both positive. So they are within the range here, within the normal. Excellent. How about this one?
Yeah.
This is left axis deviation.
Okay. Lead one is positive. AVF is negative. And do I need to do something more here? I need to look to lead two, right?
Lead two, look to lead two.
Yeah. Lead two is negative. So this is consistent with left axis deviation. So the positive, negative, and lead two confirm that it is negative. So this is left axis deviation. How about this one?
This is normal.
Normal, excellent. We have lead one positive, AVF is negative, but when we look to lead two, it is positive. So it cannot be in this direction of the left axis. It must be still within the normal axis. And this one is clearly right axis deviation. We have negative lead one, positive AVF. So it is in this direction. Okay, so basically that was the initial part about the basics of ECG, and the axis is part of the basics ECG. Any question about what I said so far?
Clear, doctor.
Okay. Yeah, go ahead, please.
No, doctor, nothing. Clear.
Nothing. Okay. No, we'll go to the ECG changes in ischemic heart disease, and it's important for you as cardiac surgeons because you will see changes sometimes pre or post-operatively. And as you know, acute coronary syndrome divided into ST segment elevation myocardial infarction, non-ST segment elevation myocardial infarction, and unstable angina. And ST segment elevation, as you know, is medical emergency, so it's important to recognize it. When we have myocardial ischemic changes and is not treated, it can go into myocardial injury, and if not treated, it goes to myocardial infarction. As you know, when we say there is ischemia, it may just decrease supply of oxygenated blood and nutrients to part of the heart. And there is hypoxia in the tissue, and still this part is reversible. What we see in ECG when we have ischemia could be one of these, or combination. So inverted T wave, ST segment depression, or rarely peaked tall T wave. Peaked tall T wave could be just, again, indicating ischemia. And most of the time, this one is followed by infarction. So if you have ischemia, just decreased blood supply at early stage, just hypoxia of the tissue is still reversible if you manage them. What we see in ECG is T wave inversion, ST segment depression, or combination. We may see also hyperacute T wave. If not treated, it goes into myocardial injury, which is more hypoxia. The muscles start to die, and this develops from endocardium to epicardium. and there is ischemia of the surrounding tissue of the myocardial injured area. In this case, we have ST segment elevation. And this is the time where somebody need to act rapidly before we go into the next step, which is myocardial infarction, which means death of the myocardial cells due to irreversible damage. And the tissue here is necrotic. And the indication, myocardial infarction by ECG is indicated when we have pathologic Q wave, when you start to see pathologic Q wave. And with time, we'll lose also the R waves, and we will just have a QS if the ischemia progressed and not managed, and infarction progressed and not managed. So there are ECG changes with ischemia, ECG changes with myocardial injury, and when we have infarction, the clue from ECG would be the presence of pathologic Q wave. ST segment is the junction between depolarization and repolarization. And if you look to the action potential of the myocardium, it is at the plateau phase of the action potential. That's why it's isoelectric, and there is no positive or negative deflection in the ST segment. When we have ischemia or endocardial damage, we tend to have ST segment depression and the leads looking to that area. When we have transmural myocardial infarction, we will have ST segment elevation in the leads looking to the area of infarction. I'm sure you remember the concept of reciprocal changes. When we have ST segment elevation in one area of the heart, in the electrodes that looking to the area, the leads or electrodes looking to the other side of the heart will show ST segment depression and T-wave inversion. So if we have inferior ST segment elevation, we will see ST segment elevation in inferior leads, 2, 3 AVF, or 2 of them at least. Then we may see reciprocal changes with ST segment depression, T-wave inversion in the lateral leads, 1 AVL. If high septal, if high lateral infarction, 1 AVL, we may see reciprocal changes in the inferior leads. Anterior usually does not have significant reciprocal changes, and posterior, we don't see it in the 12 lead unless we do posterior leads, and we will discuss this in a minute, but we may see reciprocal changes in V1 to V4. So reciprocal changes, it may or may not present, but if it's present, it indicates that the ST segment elevation is likely myocardial infarction rather than other differential diagnosis of ST segment elevation. Okay, let's take this case, a 60-year-old smoker with a history of diabetes mellitus type 2, dyslipidemia and hypertension. He has acute crushing chest pain. I volunteer to read the ECG, and in this case, you can start actually systematic. If you give us the rate, regularity, what do you think about the rhythm, and then the abnormality that you see.
Okay, Dr. Bender, so we can start with the, if it is sinus or not.
Yeah.
So we can see B waves in all, I guess in all, yeah. So it's a sinus or a sinus 1.
Yeah.
And then the rhythm is regular, I guess.
Yeah.
And then the rate, so 100, about 100.
Let's see the large box. This is in the large box, so 1, 2, 3. If it is 100, but it is less, it's about 80, because here is 75, here is 100, so it's something in between. Let's say 80 beats per minute. So it is not tachycardia. Yeah.
Yeah, and then the axis is so we have to see 1 and AVF and also lead 2. So I can say it's normal.
Yeah, negative, positive, but here is mostly positive in lead 2. Agree, it looks normal axis. Excellent. How about
and then
other
we see the ST changes in lead V2, V4, V5, also V6. They are all elevated.
Look actually in V1, you start to see ST segment elevation there. If you put the baseline, right? V1 there, V2,
yeah, above the baseline,
V3, 4, 5 for sure,
and 6.
and 6. You are right. 6 is also there. What are the criteria for ST segment elevation? When we can call the ST segment elevation is making the criteria for ST segment elevation myocardial infarction?
It's and the precordial different than the other leads. I forgot the number actually.
No problem. We'll discuss it in a minute because actually different studies, but I'll show you at the end what is the commonly agreed upon. But if you look to this one, it's very clearly more than 1 millimeter and more about 5. There's no question about this ST segment elevation in this area, which is the anterolateral area. So I'm sure you know the anatomy. So which artery is occluded here?
And the anterior, then the LAD.
Left anterior
Most
descending
likely.
artery. Yeah, most likely the left anterior descending artery. Right. Excellent.
Mhm.
Sometimes, and you can see also in lead 1 AVL, there is some ST segment, but already we know that the lateral is involved from the other side. So this is anterolateral. And generally, when we ask about the diagnosis, it's anterolateral myocardial injury. And if you look to one, so there is already Q wave, so you can call it myocardial infarction based on ECG. And we know the facial sublingual left anterior. And of course, what is the best management for this patient is to take the patient to cath lab revascularization or thrombolytic therapy if cath lab is not available. And risk factors, we know the risk factors, but we will discuss it later because even if this patient go for intervention or even needed CABG, for example, then we have to manage the risk factors. And short and long-term complications are important for you as surgeons because you will deal with these complications sometimes. So actually, basically, I'll just skip this one because you know what I'm sure. And this for myocardial infarction, when we see it in ECGs and the patient goes for intervention, we should always keep in mind the common complications that can lead to mortality and morbidity. One of the commonest is arrhythmia. They may get VF, VT, and that's actually why sometimes they die before they reach the hospital. So of course, the patient needs to be monitored and defibrillator around. They may develop systolic murmur because of papillary muscle rupture. They may have severe hypotension because of ventricular free wall rupture or ventricular septal rupture. So these mechanical complications that need surgical intervention, always when you see a patient with ST segment elevation, you should put it in mind and look for it. And if the question here, because sometimes you may see ST segment elevation that persisted more than 1 month after the infarction, then you are dealing with ventricular aneurysm if the patient has no symptoms. Remember, also, infarction can be complicated with heart block, especially if right coronary artery, including second and third degree AV block. You may have also Dressler syndrome, which is late onset pericarditis. Okay, for the anterior myocardial infarction, we know septal represented by V1, V2. Ignore V3 here. Anterior is V3, V4. If V1 to V4, this is anterior septal. And lateral, we have V5, V6. So if the anterior lead and plus the lateral lead, which is anterolateral like our patient, or we may see it changes only high lateral, which is lead 1 and AVL. For the ST segment, the best way is just to draw a line from the PR segment to the other PR segment and look to J point elevation. This is the J point, and then measure the magnitude. Again, line from the baseline and the J point and measure how much it is elevated from the baseline. Some recommend 40 milliseconds after this point or 80, but if you do it at the same level, it is fine. What you mentioned about criteria is different based on the studies. So we have the AHA ACC guidelines, we have GASTO study, we have TIMI study, and they have different criteria. Some of them only 1 millimeter in each, regardless if it is a limb lead or chest lead and others. But the commonly accepted one, I'm just this one I showed you just because you may see some differences from textbook to textbook, depends on what criteria they are used. But the commonly accepted nowadays is ST segment elevation more than 1 millimeter, more than 0.1 millivolt in all leads except V2, V3. In V2, V3, there is normally some ST segment elevation. So in females, if it is more than 1.5 millimeters, it is positive. In males above the age of 40, you need 2. Males less than 40, 2.5 millimeters. So it's 1 millimeter or more in all the leads except V2, V3. You have this different criteria, 1.5, 2, or 2.5 millimeters, or millivolt, of course, 0.15, 0.2, or 0.25 millivolt. And you need 2 leads from the same area. So if there is ST segment elevation in lead 2 only, and lead 3 AVF there is no ST segment elevation, we cannot call it inferior myocardial infarction. The same if you have only ST segment elevation in V1, for example, or V3 only, then we cannot call it anterior or septal infarction. We have to have 2 leads from the same area to call it an infarction. Remember also, new left bundle branch block is ST segment elevation equivalent. If you have isolated posterior myocardial infarction, which is very, very rare, you will see only ST segment depression in V1 to V4, then you have to do the posterior lead to make sure if the patient has posterior in mind. When we say pathologic Q wave, normally we may have some Q waves, but if the Q wave width is more than 40 milliseconds, so it's more than one small box, and this is more than 1/3, or in other references, more than 1/4 of the QRS complex. So if I measure from here to here, and it is more than 1/3 or 1/4 of the total QRS complexes, this is pathologic. It is not normal. The exception only lead 3. Sometimes we have Q waves in lead 3, not other leads, then we ignore it. It could be normal variant. So for ST segment elevation myocardial infarction, usually it started with ST segment elevation. Then we may start to see Q waves between 2 to 24 hours. If not treated, then we start to lose the R wave and we have QS, and then it may persist as QS for a long time. Okay, what do you think about this ECG?
Guys, any volunteer?
Okay, so this is around 80 beats per minute. It's regular. And however, the amplitude is very low. About the axis, it's normal. I mean, 1 is positive and AVF is, I believe, maybe more negative.
Yeah. But
And,
if you look at V2, it's zero almost, so it's still you can consider it within normal range, yeah.
All right, so normal axis, so then we have to comment on the ST elevation we have here in lead V1, no, not V1, V3. There's elevation,
Yeah.
and V2, V3, V4, V5 as well. And I'm not sure about V6, to be honest.
Look to
But,
lead 1 and AVL. Are there ST segment elevation there more than 1 millimeter?
yes.
Yes, yeah. So again, actually, this is an extensive anterolateral ST segment elevation myocardial infarction. So almost identical to the first case. When you look at the distribution, again, significant LAD occlusion. Yeah. Next one, any volunteer?
Okay, so
Walid, just a second, Nora. Walid. Thank you, Nora.
Sure.
Walid, better.
Yeah.
Yeah, please, can you?
Okay, sure.
Sorry, I don't have names. That's why I could not say, but yeah, go ahead.
So comment, the rate and rhythm looks to be regular. Access more or less normal in terms of ST segment elevation. There is ST segment elevation in lead 1, lead AVL, and lead 5 and
Not
lead
very
5
obvious there, but one AVL, what is this area? So which area represented by one AVL? Yeah, high lateral. Yeah, high lateral. So which artery usually is included if it's only high lateral?
The circumflex.
Left circumflex, excellent. What are these changes here in the inferior leads, the ST segment depression to it?
Reciprocal changes.
Reciprocal
in the
change. So it is
inferior.
not ischemia in the inferior wall, just reciprocal change of the lateral ST segment elevation myocardial infarction. Excellent. So again, 1 AVL is high lateral, V5, V6 is the lateral leads. Okay. Next case, a 55-year-old man, chest pain in emergency room. Any volunteer?
And heart rate, it's 350, below 80, I think. So it's bradycardia.
1, 2, 3, 4, 5 is 60. Yeah.
Yeah, almost. Okay, and it's regular rhythm.
Regular.
About the axis, it's normal axis, no axis deviation. And ST segment, we can see the elevation, ST segment elevation in lead 2, AVF lead 3, and V6. I think there's also.
Yeah, there is minimal segment, but it is only one lead lateral. So what do you call this?
Inferior.
Inferior what?
Yes, inferior MI. Okay.
Inferior ST segment elevation. Yeah. Do you call it myocardial injury or infarction in this case? It's just terminology, by the way. Management is the same, but terminology, would it be infarction or injury?
I think injury.
Why?
Because there is no Q wave.
Excellent, yeah. For by ECG to say infarction, we have to have a pathologic Q wave. And if you look at the inferior leads, we don't see any Q wave. So the patient did not have Q wave yet. It is still acute inferior myocardial injury. And this is the time you can salvage the myocardium if you intervene early. So there is no pathologic Q wave. Excellent. Okay, so which artery is involved?
Serene, Victor Serene.
The artery that is involved? It could be right coronary artery.
So the right coronary artery is the one because it was inferior, right?
Exactly, right. 90% of the time, circumflex rarely 10%. So this is right coronary artery most of the time. What do you think about the changes here in V1, V2? You have ST segment depression, T wave inversion. What could it be?
Could be reciprocal changes or I'm not sure actually.
Remember when the right coronary artery supplies the inferior surface of the heart, right? It also supplies two other important areas. What are these two important areas? The inferior surface with posterior and the right ventricle. So inferior, and we have the posterior and the right ventricle. If you have ST segment depression V1, V2, V1, V2 is looking to the septal and anterior part of the heart. If there is posterior infarction, we will not see ST segment elevation in this lead, we will see ST segment depression. So if you have inferior myocardial infarction and you have ST segment depression V1, V2, think about posterior myocardial infarction. How to confirm it?
We call posterior lead ECG.
Yeah, by placing posterior lead, and we'll show you how to do posterior lead. Excellent. How to look also for RV infarction if RV is involved? By doing right-sided lead. So yeah, this is the segment elevation, inferior myocardial injury. The artery is, of course, as we mentioned, right coronary artery. And remember, right coronary artery supplies the inferior surface of the heart, posterior descending artery. And there is also the RV supplied by the right coronary artery. And also remember, sinus node, 55% of the time supplied by the RCA, right coronary artery. AV node, 90% of the time supplied by the right coronary artery. So with inferior myocardial infarction, we may have first, second, or third degree AV block. Usually it's transient, but sometimes it could be persistent, and then we need a pacemaker for that. What we need if you have inferior myocardial infarction is better to do right-sided ECGs and 15 lead, it means posterior, so right-sided and posterior ECG leads. So inferior myocardial infarction could be just inferior, which is lead 2, 3 AVF, at least 2 of these showing ST segment elevation. Posterior, we have to do posterior lead. However, V1, V2 may show ST segment depression rather than elevation because it's mirror image. We are looking anteriorly and the infarction is posteriorly. Right ventricular infarction, we have to do right-sided leads. So for posterior wall myocardial infarction, if we have 15 lead ECG machine, so we have V6, then we have 7, 8, and 9, we place the V7 at the posterior axillary line, V8 at the left scapula, and V7 in the paraspinal area, left paraspinal, 7, 8, 9. If we don't have in the machine 7, 8, 9 leads, we just take 4, 5, and 6, we place them posteriorly. And when we do the recording, we just cross and label them as our posterior leads, 7, 8, and 9. If there is 1 millimeter or more ST segment elevation, and these leads indicate there is posterior infarction, like this case. In V8, V9, we have 1 millimeter ST segment elevation. For right side is easy. Most of the time, what we do in emergency room to be faster, we just take the V4 from here, from the 5th intercostal space mid-clavicular line to the same level and then right side, and we label it V4R. If it shows 1 millimeter ST segment elevation or more, it is enough. You don't need even other leads. If you wanted to do it full, you can just reverse all the leads on the other side. So take them from left side to right side and do the right-sided ECGs. But it is enough if you just V4R to do that. Why it is important to differentiate if the patient has RV infarction or not? We know the patient has already inferior MI. What's important to distinction if he has right or if he has RV infarction?
So I mean, sorry, clinically, if he's having RV infarction, then the patient is having RV failure. So this is important clinically. And
yeah, in aspect number 1, prognosis is very poor. Second, we should avoid
management-wise.
We should avoid nitroglycerin, the
The management.
Yeah, exactly, in the management, you're right. And we have to give fluid to maintain the circulation. So avoid vasodilators, nitroglycerin, morphine, give lots of fluid to maintain the circulation. Excellent. Just a reminder again, inferior surface of the heart leads to 3 AVF, septal area V1, V2, anterior V3, V4, lateral V5, V6, high lateral 1 AVL. And of course, here's the left anterior descending artery. Here is the circumflex area, and here is the right coronary artery. However, circumflex sometimes can supply that area. Okay. Remember, when you have ST segment elevation, not every ST segment elevation is myocardial infarction. We have the condition called benign early repolarization. I think we will have an ECG regarding that. We may have acute pericarditis. Pericarditis, remember, usually diffuse ST segment elevation, concave. We have PR segment depression. And generally, we start with ST segment elevation. ST segment comes to the baseline, and then we have two-wave inversion. With time, left ventricular hypertrophy, bundle branch block, hyperkalemia, hypothermia, sometimes CNS pathologies like hemorrhage, Brugada syndrome. We'll discuss ECGs later, inshallah. Electrical cardioversion. We have ST segment changes related to these conditions. So not every ST segment elevation is acute ST segment elevation myocardial infarction, but it's important to rule out ST segment elevation myocardial infarction because it is life-threatening. Look now at another case here, a 60-year-old man with chest pain, and he had elevated troponin T in emergency room. What do you think of the ECG, and what is your diagnosis? Any volunteer?
Guys, any volunteer? We can take Amjad. Amjad Banawi. Yeah.
Yes.
Yes, hi. Can you interpret?
Hi. Yeah, I'm just driving. I just stopped. So we can see the ECG. So with sinus, I can see P wave. The heart rate is regular, or maybe now a little bit tachycardic, comparing the big squares.
Yeah, 1, 2, 3, 4. Yeah, it's actually less than 100, so still within.
Less than 100.
Yeah.
Yeah, because from the mobile, I just maximize.
I know it's not easy, right?
So this is the regarding the regularity and the heart rate.
So it is sinus rhythm within the normal range, and it's regular. Okay, axis is normal or abnormal here?
The axis is positive from lead 1 and lead AVF and 2. Yeah, it's a normal axis deviation.
Normal axis, I see.
Yeah.
Any other abnormalities you could see in this ECG?
Let's see. Oh, I think there is a T inversion.
Yeah.
Yeah. At least V2, V3.
Yeah.
Right.
So if you think about this 60 years old and he has chest pain and troponin is elevated and we have these ECG changes, what do you call this condition?
Anterior MI.
Okay. What kind of MI? Is it ST segment elevation or non-ST segment elevation?
No, it is ST elevation. STEMI.
Do you see any ST segment elevation in any part of this ECG? This is actually T wave inversion, but there is no ST segment elevation, right?
Okay.
Yeah, so it is non-ST segment elevation.
He has a positive trope. Okay, it's non-ST,
non-ST. Yeah, exactly. Non-ST segment elevation myocardial infarction. So that is the diagnosis here. And by the way, ST segment depression T wave inversion does not localize, not like ST segment elevation where you localize, but we need to see these changes in the anterolateral area. But ST segment elevation localize, ST segment depression T wave inversion does not localize. What if the same patient but cardiac enzymes negative? Then we are dealing with unstable angina, right? So that's just to show you this one. We'll just do a quick ECG practice for ischemic heart disease now, because we're just dealing with ischemic heart disease. So 70-year-old man with decreased level of consciousness. What is your diagnosis here?
Could be anterior MI.
Excellent. You have ST segment elevation in V2, V3, V4. 5, we don't see it much. Remember, V1, V2 is septal, 3, 4 is anterior. So this is anterior septal myocardial infarction. If you say just anterior is okay, because septal is included when you say anterior. And this one.
Again, same thing, anterior
anterior myocardial infarction, right? If you look to the V5, there is minimal ST segment elevation, but we don't see it in other leads in the lateral, so still anterior MI. 67-year-old lady with diabetes and hypertension. You have the answer, but why you convinced me why it is old? Just because we see there's no R wave, there's Q waves already in anterior leads. So if patient presented like this, there is no R waves. Remember that when we say R wave progression should be R wave is bigger in V2 than 3 and then there. And you see Q waves already in V4, V5. So what it indicates is old anterior septal myocardial infarction. The answer was there, so we'll skip it. A 55-year-old man with chest pain. Again.
Inferior STEMI.
Inferior, excellent. If you look there, it's not as obvious as the first, but it meets the criteria. More than 1 millimeter in 2 at least leads. Here you have all the 3 leads actually. in the inferior. And remember what to do next if you have inferior myocardial infarction, which area you need to look for?
The right and posterior.
Right-sided leads and posterior leads. Excellent. Next case, 75-year-old man with chest pain.
Abdurrahman Ruwaili, can you please?
It will be very easy, Abdurrahman. You can read it from down, but just look to it and see what you think.
Okay, Faisal Ghamdi, please.
It is in the inferior reed, and because there is some reciprocal changes in the anterior, so we consider there is a posterior MI.
Excellent. And when the posterior lead is done, V7, 8, and 9, you can see ST segment elevation, indicating that this is inferior and posterior myocardial infarction. Another one here, 50-year-old man with chest pain.
So how can you please? Saha? Okay, anyone else?
There's written old inferior posterior myocardial infarction. So if we say inferior,
why convince me? It is inferior.
Why inferior? There's, I mean, it's obvious the Q wave only in the.
Excellent. There's pathologic Q waves in the inferior leads.
Yeah, but I mean the Q waves is not clear in 2, and it's clear in lead 3, not in 2.
Yeah, you have to at least 2 leads. It's clear in AVF, clear in lead 3. Lead to agree with you, it is maybe not pathological, does not meet the criteria, but they have at least 2 leads. So it's old infarction. If you see that one, it just indicate that the patient already had infarction before. Next one.
Can we كمان برضو نقول إنه ال T inversion it's indicate برضو old infarction in the previous one?
Sorry, what's that? Sorry.
Old infarction in inferior leads, just according to the Q waves, or also according to the T inversion in the same leads?
Mainly the Q wave, pathologic Q waves. And of course, always we have the history why Q wave usually is late. However, it can present like within 2 hours of onset inferior MI. So if the patient is still having acute chest pain and the pain is only for a couple of hours, we still should treat as acute ST segment elevation. We go with the intervention. However, if the chest pain is there for 2 to 3 days, we know that the area is infarcted because the pathologic Q wave. I did not put the duration here of the chest pain, but if it is like 2 to 3 days, the presence of Q waves indicate that already the area is infarcted.
Old infarction. Thank you.
You're welcome. So again, a 62-year-old chest pain, patient diabetes, post-cabbage, troponin is elevated, CK is 200.
You mean his fresh post-op or stays post-cabbage long time?
In a cabbage long time ago, but he presented now with emergency room chest pain. It can happen also immediately after cabbage, by the way.
So and many leads that he's having ST depression.
Right. Anterior. So our diagnosis is?
And he's having high cardiac enzymes as well.
Yeah.
Yeah, so maybe he's having then occluded grafts.
Yeah, so we'll have non-ST segment elevation myocardial infarction by diagnosis. Then of course you have to investigate for his graft, right? Excellent.
Yeah.
The next case is similar. However, we have negative cardiac enzymes. Just to let you know that this, we call it unstable angina, of course. So if the patient has chest pain, risk factors is there. Even if the enzymes are negative, we still should treat as acute coronary syndrome, and this would be unstable angina. We cannot discharge a patient unless we observe him for 24, 48 hours and the chest pain is gone. If he's still having constant chest pain, even if the enzymes are negative, it may be still unstable angina. And unstable angina, by the way, by definition, if it is new onset angina, angina increasing in severity, duration, or frequency, angina at rest. These three things considered as unstable at any time. Okay. 39-year-old female with hypertension and hypercholesterolemia present to ER with chest pain.
So she's bradycardic, right? And so she's in sinus bradycardia, actually.
Yeah.
Yeah. But the ST segments here on V4, V5, V6, I think they're not elevated, right? It's not significant.
Yeah. How about V3? Is it elevated here? V2.
It's above the J point, you know, the baseline. It's above the baseline, actually.
Yeah.
Yeah.
So do you think
she's having the ST elevation? Yeah. MI.
Yeah, that is in V2 or V3.
Yeah. Actually, this condition is interesting because this is what we call early repolarization. Remember this terminology, early repolarization. If you have ST segment elevation like this, and you see that notch here, small notch, not all the time, but there is small notch, and it is concave, and the T wave is upright, and usually young people. You see that one, we consider it early repolarization. The thing is, when we see a patient like this, usually we give them a copy of their ECG. So if they present to emergency room with chest pain, and we see these changes, and we see the old ECG and the same, we think this is just early repolarization, and it's benign. Usually younger than this, usually see it in the 20s, early 30s, not 39, but it, you know, if some patient may have it persistent for some time. But the clue here that number one, there is a small notch. It is concave type, and the T wave is upright. And this is consistent with early repolarization rather than ST segment elevation, myocardial infarction. This is early, I mean, this is a benign condition. There is early repolarization syndrome. I'm sure you heard about it. And that when the patient has sudden cardiac death and they survive it, or they have strong family history of sudden death. And usually they have early repolarization in the inferior and lateral. So inferior lateral or inferolateral together, then they may have early repolarization syndrome. It's very rare. But this morphology here between V1 to V3, usually benign ST segment elevation and called early repolarization.
So Dr. Bender, what if they persistently having chest pain? Then they're gonna complain.
Exactly.
I mean, we do something for them.
That's actually why we give them all with a copy of their ECGs, because in young female, the chest pain most of the time is non-cardiac, and we still see them in the clinic, and they have mostly musculoskeletal and others. So you look at the criteria of the chest pain, and if it doesn't look like ischemic with this ECG, then it's early repolarization. If you're still in doubt, you can do further workup by cardiac enzymes, which is, in this case, of course, will come negative. So the characteristic of the chest pain is important. They will not have usually typical, and we see this morphology. I've seen few cases that actually they receive thrombolytic therapy and occasionally taken to the cath lab because of changes like this. And that's why we ask them to take a copy of their ECG if we know for sure that their coronaries are normal and this is just early repolarization. So when they go to emergency room for chest pain for other reasons, they are not misinterpreted as ST segment elevation myocardial infarction.
In this patient with this ECG and no elevation in cardiac enzyme, so we just, and with this age, so no need for further.
No need for further, especially if the characteristic of the pain is not typical ischemic chest pain, then you just ignore it. Most likely this early repolarization, right?
What about transmittal angina? Some patients, they come with ECG changes. It's usually comes with diffuse or specific leads.
It actually depends on the area because it is a spasm of the artery. So they may have ST segment elevation transient in inferior leads, if this is right coronary artery, in the LAD territory if it's LAD, in the circ if it's circ, which is rare circ. So they have transient. And the difference between them and the other ST segment elevation is that the ST segment is just transient. And that's actually why the recommendation, if you have ST segment elevation, myocardial infarction, while preparing everything, repeat ECG in 5 minutes. If the pain disappeared and the ST segment is back to the baseline, this cannot be ST segment elevation myocardial infarction. This is just a spasm of the artery, which is Prinzmetal's angina. If the ST segment persisted, it means this is ST segment elevation myocardial infarction. It's a good point. Okay, I think just for the sake of time and not to give too much, next time, inshallah, if you mind, we can discuss the brady and tachyarrhythmias and an example of them. Is it okay for everybody? Just not to mix things together.
Sure, Dr. Bender, sure.
Sure.
It will be our
Dr.
pleasure to
Thank you
have
so
you
much.
again in the next session, inshallah.
Inshallah.
Okay, so Dr.
Yeah.
Bender, I have a question on ST elevation and ST segment changes.
Right.
There is some, as you said, if there is a ischemia, we'll see some ST depression or other changes. And if there is an injury, we'll see ST elevation. And if there is infarction already, we'll see Q wave. What is the basic, at the cellular level, what happens that makes the ECG present like this? And why it's different from only, what's changed? Is it the flow of the electrical waves change the direction, or only the muscle repolarization of the muscle is different?
Yeah, to be honest, nobody knows exactly what is it, but if it is just ischemia or subendocardial infarction, the wave of the current usually is moving to that area, and this is healthy tissue. And if the lead is there, it will just show ST segment depression. If the whole area is infarcted, what we see is what is happening in the other side, and which will present as ST segment elevation. There's lots of discussion in the physiology box about what's happening at the cellular level, but it is not very clear. But basically, if you have only ischemia or subendocardium, usually the ST segment will be depressed. If you have total myocardial injury and this part is gone, then we will have the ST segment elevation from the other part around that area.
Okay, thank you. The other question, why we have, you said in V3, V2, the criteria of ST segment elevation, V2, V3, maybe we have normally some degree of ST elevation. And why it's different from young male to older male and female?
Yeah, this is actually just observation from normal people, because, always when you compare something, we look to the normal people. So usually in young females, they have ST segment normal variant there. It's about 1.5. So anything above 1.5 millimeter is abnormal. Young males, actually, it can be more than 2.5. So that's why we look for something which is beyond what we see normally. And for male, older than 40 is about 2 millimeters. So this is just normal observation in the location of these leads. If you take normal people, you see some ST segment elevation in this lead V2, V3. Which depends on gender and age, of course. It's more in males than females, and younger males, they tend to have more ST segment elevation than others.
Okay, thank you.
Yeah.
Any other questions? So, Dr. Bender?
Yeah, doctor, I have one question, please. In ECG post-CABG, what is the difference in interpretation for ECG for those patients? And is it the same approach, ST elevation, ST depression? Is it the same approach? And
yeah, it is the same. There's no difference. So we still treat them the same. Sometimes because we are putting the bandage and the ECG electrodes may not place in the right place. So the morphology may look a little bit different, but we should strive to make the same location of the leads as it's supposed to be.
So ST elevation in those patients means ST elevation and new infarction for them.
Yeah, if they have chest pain and other criteria, ECG is part of the equation. So we have to take the history, we have to take the ECG, and sometimes if not ST segment elevation like depression and T-wave, we look also for cardiac enzymes.
Okay, thank you.
I think the tertiary means that we have some patients post-op, they have ST elevation. They do have it, but it's not significant because they are just fresh post-op. Then you look to the also the cardiac enzymes might be high also, but not to that extent that you call it infarction. So yeah, your enzymes might be high, but the ECG
exactly.
itself,
By the way,
per se, you have to see the ECG itself and the clinical situation.
The clinical, exactly. I think the clinical is most important. But in the new criteria, when they classify the myocardial infarction, I did not put it here because it's a little bit long. They include post PCI and post CABG also as one of the criteria if they have positive enzymes after the after. Sometimes we'll not take them to the cath lab right away if it's just minimal changes. But if there is, for example, crushing chest pain, patient hemodynamically unstable, they need to be taken to cath lab. If they don't have chest pain or they're hemodynamically stable, we observe them. But this is part of the small myocardial infarction after intervention, whether it's PCI or CABG.
Okay, fair enough. Thank you so much.
You're welcome. Any other questions?
If no more questions, guys, then we can conclude Dr. Bender's lecture. Any comment? Okay, then thank you so much, Dr. Bender. It was just a great having you, and with all those beneficial discussions. We're pleased to have you again.
Thank you very much.
Thank you so much for your lecture. Yeah. So
you.
we can start, guys, like by 2:30. We can have just a short break, and then we can get back to the lecture. Just the next presenter, if you can please prepare.
Thank you very much.
Thank you, Lisa. Dr. Hani. Dr. Hani Bernawi.
موجود.
Yeah, please, can you prepare your lecture?
Okay.
CVD 44, yes.
Dr. Hani can start. If you are ready.
Can you see the slides?
Yes, that's it. Fadal.
Assalamu alaikum. My name is Hani Barnawi and I'm an R1 cardiac surgery at King Faisal Specialist Hospital Research Center, Jeddah. So I'm going to talk about post cardiac surgery arrhythmia, cardiac arrhythmia, and block. So we'll start by definition of the arrhythmia. Arrhythmia is any rhythm that is not normal, sinus rhythm with a normal AV conduction. For the incidence of the arrhythmia following cardiac surgery, open heart surgery, it is fairly common, noted in about 25% of patients. That is for the supraventricular arrhythmias. As for the ventricular arrhythmias, are less common, but they usually reflect some degree of myocardial injury. For the cardiac action potential, this cycle, it starts by phase 0 with the sodium influx, and then the potassium efflux, followed by the calcium influx, and with some potassium efflux at the same time, the plateau. After that, follows by the calcium closure, leading to potassium efflux, and then the sodium potassium ATPase pump to stabilize the membrane. For the pathogenesis, it could be to either injury or damage, re-entry, automaticity, mutations, or ectopic foci. For the causes post-cardiac surgery, we can divide it into cardiac-related, respiratory-related, and other. For the cardiac problems, could be underlying heart disease, pre-existing arrhythmia, poor intra-op myocardial protection, and inflammation. For the respiratory problems, we have hypoxia, acidosis, pneumothorax. For the other causes, might be electrolyte imbalance, intracardiac lines, surgical trauma, as in arteriotomy, ventriculotomy, valve surgeries. For also the drugs could affect the rhythm. Others like hypothermia, fever, pain, and gastric dilation all could lead to any type of arrhythmia. So for the classification of the arrhythmia, we have either tachy or bradyarrhythmia. For the tachyarrhythmia, there are two types. We have the narrow complex or the SVT and the wide complex or the ventricular arrhythmia. When the QRS width is more than 3 small boxes, small squares, or 120 milliseconds. So I'm going to start by the tachyarrhythmia. As I said, we have narrow complex, or also you can call it supraventricular tachyarrhythmia, or the ventricular arrhythmia, the wide complex. For the narrow complex, it is defined as sustained non-sinus related acceleration of the cardiac rhythm originating above the AV node, hence supraventricular arrhythmia. The atrial arrhythmias occur most often within the few days after the surgery. I'm going to talk about the most commonly seen arrhythmia: sinus tachycardia, atrial fibrillation, and atrial flutter. For the perioperative risk factor, we're talking about atrial injury from the surgical handling, acute atrial enlargement from the pressure or volume overload, atrial ischemia, long bypass, pulmonary complication, inflammation, and electrolytes. For the SVTs, 15 to 40% of patients in the early post-operative period following coronary artery bypass graft surgery. But for the atrial fibrillation, which is the most common arrhythmia post-surgery, occurs in 37 to 50% after valve surgery, and it can reach up to 60% with the underlying valve plus CABG surgery. For the sinus tachycardia, when the heart rate is more than 100 beats per minute, why it is a problem? Because a prolonged tachycardia for long duration can induce ischemia, especially in coronary artery disease patients. What might be the causes? Bleeding, pain, hypovolemia, thyrotoxicosis. These are all can be causes for sinus tachy. For its management, first you should manage the underlying cause. If it couldn't, then you could add beta blocker for rate control. For the atrial fibrillation, it is among patients with no prior history of atrial arrhythmia. Atrial fibrillation is usually self-limited, and 15 to 30% convert within 2 hours, and up to 80% in the first day post-op. The mean duration of the atrial fibrillation in one report was 11 to 12 hours, and reaching more than 90% from 6 to 8 weeks following the surgery. They will convert them. What might be the causes? Raised atrial pressure, atrial fibrosis, electrolytes, and injury. This is an ECG for atrial fibrillation with the irregular rhythm, and with the fibrillatory waves and no P waves. For the types of atrial fibrillation, we have paroxysmal AFib that terminates spontaneously or within 7 days of the onset. The persistent AFib that fails to self-terminate even within 7 days. The long-standing, if it is more than 1 year, and there is the permanent. The permanent, when the when the patient and the physician itself decided there is no longer need for the rhythm control, only would be for the rate control. For the treatment of the atrial fibrillation, we have two main categories. If the patient is stable or unstable. If the patient is unstable, then cardioversion should be used immediately. And if the patient is stable, the latest guideline is to go for the rate control. The rate control should be started by beta blocker, and calcium channel blocker can be added. For the rhythm control, we have amiodarone and cardioversion if the patient, as a second line, if the patient is stable. Anticoagulation to start heparin or warfarin to avoid its complication, especially the stroke. For the atrial flutter is relatively uncommon compared to the atrial fibrillation. It is more associated with ischemia, and the rate ranges from 280 to 350 atrial rate per minute. For the diagnosis, as you can see, the ECG here, it shows the sawtooth ECG. For the management of the atrial flutter, it is exactly as the atrial fibrillation. Apart from the atrial pacing, you can use atrial pacing because it's re-entry here, so you can break the circuit. Override, so breaks the circuit. That was for the narrow complex. Now we're gonna talk for the wide complex or the ventricular arrhythmia when the QRS is more than 3 small squares. We have the 4 type. Of course, there are many, but most common, we have the PVC, the VT, VF, and Torsades. For the PVCs, it results from an ectopic foci arising from below the AV node, hence the ventricular arrhythmia, which gives a wide QRS complex. It rarely leads to sustained ventricular tachyarrhythmia. What might be the causes? It might be ischemia, drugs, and or electrolytes. For the diagnosis, here is the ECG, which will show the premature ventricular contraction with the compensatory pulse. For treatment, it is usually benign, so no need for management. But if it increased more than 5 or hemodynamically compromised, then electrolyte correction must be managed. Magnesium sulfate can be used, lidocaine, and amiodarone. For the ventricular tachycardia, it defined as 3 or more consecutive PVCs. It is categorized either mono or polymorphic ventricular tachycardia. Monomorphic, when the wave shapes the same, it has the same shape all over. So this is monomorphic. Polymorphic, when different shapes. Sustained versus non-sustained, this represent the timing of the ventricular tachycardia. If it is less than 30 seconds, then it is sustained. Non-sustained, if it is more than 30 seconds, then it is sustained. Here, as you can see, the difference between monomorphic versus the polymorphic. the shape of the waves. And the monomorphic, it is the same shape all over, and then the polymorphic, it can interchange. For the for the ventricular fibrillation, it's a rapid disorganized ventricular arrhythmia resulting in no uniform ventricular activation or contraction, and no cardiac output, and no recordable blood pressure. It is usually initiated from an ischemic myocardium or apparent foci. On the ECG, there are no defined QRS complexes, shows shapeless rapid circulation, and no pulse oximetry. For the treatment of both the ventricular, the VT and the VF, in the VT, ventricular overdrive pacing can be used to terminate the re-entry circuit. The cardioversion, for patient is stable or unstable. For the VT, if it is unstable, then cardioversion should be used. For the VF, CPR or cardiac massage should be initiated, and ACLS protocol also can be initiated. Further medication to be used, lidocaine can be used, along also amiodarone can be used. For the Torsades de Pointes, if the polymorphic VT with QT prolongation, it is called Torsades. As you can see, it's here also the interchanging the length of the weights. For the treatment, immediately cardioversion, potassium chloride and magnesium can be used as a medication, as a drug management. For the bradyarrhythmia, they are particularly common after valve surgery, and are probably a consequence of direct surgical injury and local edema, either to the conduction system or around the conduction system. We have two types: sinus bradycardia, and we have a heart block. For the sinus bradycardia, sinus bradycardia is present when the sinus rate, of course, is less than 60 beats per minute. It can be symptomatic or asymptomatic. For the causes, it might be drugs, hypothermia, underlying hypothyroidism. For the management, for the asymptomatic, no need for any intervention. If the patient is symptomatic, then atropine can be used. If not, dopamine infusion should be started. And of course, pacer wire pacing itself, either pacer wire or pacer already placed in the OR. For the heart block, we have first degree, second degree, and third degree heart block. For the first degree, it is a simple fixed prolongation of the PR interval. So it is fixed, not progressive. Usually, usually there is no need for any intervention for this regard. But if the patient went into symptomatic progressive higher degree of block or symptomatic brady, then an intervention should be made. For the second degree, we have two types. We have the MOPS type 1 or Wickenbach, which is a progressive PR prolongation until a non-conducted P wave occurs, until a sudden drop occurs. For the second type, which is MOPS type 2, the PR interval are constant. There is no progressive prolongation, but there is a sudden P wave drop or a sudden non-conductive P wave occurrence. For the third degree heart block, there is a complete AV dissociation because of the atria and the ventricular eyes are separated. Here, the ECG to differentiate between the first, second, and the third. For the first, as you can see, there is a fixed PR interval. For the second, Wickenbach or MOPS type 1, there is a progressive prolongation in the PR interval leading to a drop or non-conductive P wave. For the type 2, MOPS type 2, the PR interval is fixed, but there is a sudden drop. For the third degree, the atrium is pacing alone and the ventricle is going alone. There is a fixed line between the P to P ratio and the QRS to QRS. For the intervention, as I said, for the first degree AV block, mostly there is no need for any intervention, but monitoring should be done. Second degree AV block, we have the Wickenbach or the MOPS type 2. For the Wickenbach, no need unless the ventricular rate is low. So in this case, it should be treated by pacing, AV pacing, atrioventricular pacing. For the MOPS type 2, also it needs an atrioventricular pacing, permanent pacing. Same goes for the third degree heart block. That was the end of my lecture. Do you have any question?
Any comments, guys, or questions to Hani?
Thank you, Hani.
Okay.
Okay.
Thank you, Hani, and we can resume our activity by 3 p.m. Please, the next presenter to prepare. Dr. Ahmed Al-Ghamdi. Can you please prepare your slides?
Yeah, sure.
We'll start after 2 minutes, okay? 3 p.m. sharp. Okay, Dr. Ahmed.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon, everybody. Today, inshallah, I'm going to talk about the total pericardiectomy, which is also known as the decortication of the heart, the surgical techniques and the outcomes. So, as a brief introduction, I'm going to talk about the anatomy of the pericardium, which consists of the visceral monolayer, which is adherent to the epicardial surface of the heart, and it goes with continuity with the parietal pericardium, which is a fibroelastic layer and forms a sac, which is known as a pericardial sac, that's surrounding the heart and that contains a thin layer of the fluid. When there is a larger amount of fluid accumulate within the sac or within the pericardium, or when the pericardium becomes scarred and inelastic as a consequence of the inflammation, one of the pericardial compressive syndromes may occur, which is cardiac tamponading, constrictive pericarditis, or a mix of both, which is known as effusive constrictive pericarditis. The chronic constrictive pericarditis, which is the end stage of the chronic inflammatory and non-inflammatory process that result in a thick, fibrotic, constricting, and sometimes a calcific pericardium. Eventually, this process leads to impairment of diastolic filling and the right heart and causing right heart failure. So the hemodynamic effect of the constrictive pericardium, which cause dynamic changes in the right and left heart filling with respiration. Also, it causes elevation and equalization of the cardiac film pressures of both ventricles and atria and increase the venous pressure, which leads to decreased cardiac output. Patients will have symptoms of dyspnea on exertion, even they will complain of edema, chest discomfort, fatigue, and also in case of severe cases, ascites is present, so abdominal symptoms. The signs that we are looking for is jugular venous distension, step deep jugular Y descent on the venous tracing, cosmal signs, pleural effusion, and also no hepatomegaly and ascites. Etiology of constrictive pericarditis vary widely, which is the idiopathic or viral account for the most common causes, up to 60%. Post-cardiac surgery, also one of the causes of pericarditis, account for 11 to 37%. Post-radiation therapy, 2 to 31, and this primarily after Hodgkin disease or breast cancer. Connective tissue disorder also will cause the constrictive pericarditis, up to 7%. Post-infectious, which is most commonly that TB, account for 15%, and miscellaneous causes like malignancy, trauma, or even a drug. According to the European Society of Cardiology Guidelines 2015, the pericardiectomy is the accepted standard of treatment in patients with chronic constrictive pericarditis who have persistent and prominent symptoms, such as NIAHA class 3 or 4. And the surgery should be considered cautiously in patients with either mild or very advanced disease, and in those with radiation-induced constriction, myocardial dysfunction, or significant renal dysfunction, because the outcome is very poor in these patients. Surgical removal of the pericardium has a significant operative mortality, ranging from 6 to 12%, and the pericardiotomy must be as complete as is technically feasible and should be performed by experienced surgeon. Here is the recommendation. So the mainstay of treatment of CP is pericardiotomy, which is class 1. Medical therapy of specific pericarditis like TB is recommended to prevent the progression of constriction. Empirical anti-inflammatory therapy may be considered in cases with transient or new diagnosis, and this is class 2B. So moving to the surgical techniques, the patient is fully monitored in order to evaluate the hemodynamic. Pericardiotomy can be performed through either median sternotomy or a left anterolateral thoracotomy. The advantages of the median sternotomy, it provides a good access to the right ventricle, right atrium, and also the great vessels. And this enabling a good clearance of a diseased pericardium from phrenic nerve to the other phrenic nerve. While the left anterior thoracotomy is preferred mainly in cases of infective purulent pericarditis in order to avoid external infection postoperatively. Femoral access sites are kept open for the left anterior thoracotomy in case that we need a cardiopulmonary bypass. So as usual, the patient is prepared and draped in the standard manner with the groin available if emergency CPB should become necessary. Median sternotomy is performed. The pericardium is initially divided in the midline, as shown here. The dissection is done sharply with scissor, cautery, or harmonic scalpel. Dissection can sometimes be used. It is important that the coronary arteries be visualized as the pericardium is removed. And when we are unable to visualize the coronary artery, that indicates that the dissection plane is not deep enough. And so we have to carry more to this pericardium, but we have to be careful to not injure any chamber of the heart. The edges of the cut of pericardium can be grasped with the cochar or else clamped to easily facilitate the dissection. And also retraction of the heart can be done with the left hand and the sponge on the heart by the operating surgeon. So as shown here, this is the phrenic nerves in the lateral sides of the pericardium. Here, this is an intraoperatively photography, shows the anterior mediastinum dissection with the blunt sharp dissection with the scissor and swab assisted dissection. And we have extended the dissection plane laterally to up to the phrenic nerve. Both pleura spaces are entered to view the phrenic nerves and to drain any pleural effusion. The other photograph on the right side, it is showed better diastolic relaxation, just we open the pericardium. And again, the dissection proceeds laterally on the right side to remove the pericardium surrounding the right atrium. And the posterior extent of this dissection is approximately 1 centimeter anterior to the right phrenic nerve. Then we move to the left-sided, the posterior extent of the anterior pericardium, also approximately 1 centimeter anterior to the left phrenic. And at that time, the LAD should be visualized when we remove the pericardium. If we are not seeing the pericardium, the LAD, it means that there is still pericardium on the heart. So after removal of the anterior pericardium, the LAD is well visualized. We have to do a more additional dissection between the pericardium and the posterior lateral LV wall along the inferior walls of the left and right ventricle, as shown in dots here. The pericardium posterior to the left phrenic nerve down to the left side pulmonary vein is dissected with the sparing of the left phrenic nerve as a pedicle. The diaphragmatic pericardium is dissected off the inferior left and right ventricular wall as well. And we have to take care when freeing up the left ventricular apex, because the left phrenic nerve is in close proximity, and it is difficult to visualize because a large amount of fat in this area. So after removing the posterior pericardium behind the left phrenic nerve, the pericardium adjacent to the diaphragm also is removed. The right phrenic nerve has been preserved from the superior mediastinum down to the diaphragm, just anterior to the pulmonary veins on the right side, as shown here in the figure. So the left phrenic has been preserved on intact pedicle from the superior mediastinum down to the diaphragm, as well as the right side. The completed pericardiotomy demonstrates a complete removal of all sides of the pericardium, except that which is posterior to the left atrium. The edges of the cut of the pericardium are treated gently with electrocautery to obtain a good hemostasis. All of the coronary arteries are typically well visualized when the pericardiotomy has been performed in the correct plane. As I said, the operative mortality is very high for these patients, and the reported early hospital mortality was 10 to 15%. More recently, with advanced in cardiovascular surgical techniques and the introduce of cardiopulmonary bypass, it has been reduced to about 5%. One of the studies, Natif and colleagues, reported 2 to 3% operative mortality in 84 patients operated upon between 1979 to 1988 using a median sternotomy, and about 25% of post-operative in-hospital death occur from acute or subacute cardiac failure. Post-operative hemorrhage and respiratory failure are the modes of early deaths. Outcomes of such procedure, it depends on the etiology, as shown here. If the etiology is idiopathic, they are doing great. Best prognosis with the rate of 88%. If it is post-cardiac surgery, it is down to the 66. And the worst prognosis is those patients who had constrictive pericarditis post-radiation. So according to the guideline, the predictors of poor overall survival are the prior radiation, patient with chronic kidney disease or worse renal, and NIAHA class for higher pulmonary artery systolic pressure, abnormal left ventricle, and old ages. So if you have any question, please.
Thank you, Dr. Ahmed. I just wanted to share one case with you. So I remember that we operated on one young lady. I think she was about like 37 years old, and she had we had to do pericardiectomy for her, and then it was really calcified and thick, really. So when we were trying to remove it, she had bleeding to that extent that she was about to arrest, actually. Okay, so we went on pump quickly, and we repaired the injury and everything. It was really thick and really attached to the area, so we couldn't. There was an injury, and we repaired it. So sometimes it will be really difficult. It's not a straightforward pericardiectomy. And she survived, alhamdulillah, she's fine.
Do you recall the cause of this constrictive pericarditis? Infection or post-radiation?
Well, we tried to find the cause of that one. We have sent for TB and everything, and there was no clear reason or cause. What causes this? I remember we consulted ID, we have sent everything, but there was no clear reason. And she was young, like 35, 37.
You followed up the patient, so there is any positive result or history?
No. No history of any positive thing, no TB, nothing.
Yeah, so almost idiopathic.
Yes,
you're right. The constrictive pericarditis is a very, very tough surgery. I haven't seen it, to be honest, but when I discussed with the surgeon, they said it is very difficult and it is poor outcome. Because the constrictive pericarditis causes more calcification on the epicardium that you cannot get it from the heart.
Exactly.
Yeah.
So this is what happened with this lady. It was really calcified and thick.
So you did there were an injury to the chamber or the coronary arteries?
Well, I guess it was like I'm not sure. I didn't see the area, but it was like near to the IVC. Down there, so it was a difficult area to reach.
So you go on bypass and drain the heart and
and repaired it.
Thank you for sharing that. I haven't seen it, to be honest. I'm in Mecca, but I haven't seen it.
So guys, any comments, any questions to Dr. Ahmed?
Ahmed.
Yes.
First of all, thank you for your presentation. And I have a question. Does it matter how much we excise of the pericardium? Like, is it partial or complete? Does it matter in the post-op and the...
Yeah,
Could you just briefly summarize, like, what is the importance?
Yeah, it's good point. So pericardiectomy, there is a partial or the just anterior pericardiectomy or a full pericardiectomy, which is also known as a radical pericardiectomy. As I've read that we have to do the total pericardiectomy radical. So we remove all the pericardium. If you leave any pericardium, it may be restrict the heart and to cause the symptoms even. So it's better to remove. If you cannot remove it, you don't have anything. You have to build the bullet and خلاص. Accept what you did, but it is good. If you remove it all, it's a good prognosis. If it's still there, it might have some restriction on the heart.
Great, thank you.
Okay.
Okay, then, if no more comments, then we are gonna conclude here. Thank you for the presenters, and thank you for the audience, for the patience. Thank you so much. See you next week.